So in video one, we talked about the different types of epidemiological research studies that are out there and the differences between the three observational epidemiological research studies. And we also talked about different terminology that are essential within public health and epidemiology. So in this particular video, we're going to talk about epidemiological measures of oral diseases. And specifically, we're going to talk about and define prevalence, incidence, and relative risk. And then we're going to look at some other measures of oral diseases in terms of counts, proportions, rates, and index. And the plural of the index is indices. So you'll hear me call the plural of index indices in multiple places within this video. And then we're going to talk about, we're really going to hone in on the index and look at the good qualities of an index as well as the different classifications of the indices that are out there. So let's start by talking about prevalence. Prevalence and incidence are two huge terms within epidemiology, and you'll see it quite a bit in research studies, and it pops up quite a bit on boards as well. So you want to make sure that you know the difference between prevalence and incidence. And after I define both prevalence and incidence, I'll give you a little mnemonic way for how to remember it, because honestly, a lot of us get those terms mixed up and we use them interchangeably, and that's wrong, honestly. So let's start with prevalence. Prevalence is really how widespread a disease is in a group of people. So it really refers to the estimated population of people who are managing a disease at any given time. So when epidemiologists are trying to determine the prevalence of a disease, they are collecting data from a group of people once, only one time. And what they're looking at is how many existing cases are within that community at that given point in time. To get prevalence and to calculate prevalence, for your numerator, it is the number of existing cases that you see whenever you're collecting the data, and then you're going to divide it by the population at risk, and to get it as a percentage, you will multiply that number by 100, and you can state it in percentages. So for instance, let's say I was really concerned about the prevalence of dental caries within sixth grade population within Jefferson County. So that would mean that I would go and I would look at the sixth graders within a school within Jefferson County, and let's say I determined that 125 of those sixth graders, there was 125 sixth graders within that school. And whenever I looked at 125 of those sixth graders, I see that 40 kids have carious lesions. So 40 would go in the numerator, and then 125 would go in the denominator, because that's the population at risk. So I would do 40 divided by 125, and then that would give me 0.32. And then if I wanted to express that as a percentage, then I would multiply it by 100, and I could say 32% of the sixth graders at whatever school that I went and screened at had dental caries. You could even say the caries prevalence at such and such school was 32%. And that meant that 32% of the sixth graders had existing caries at that particular point in time. So one point at a time, you're collecting data only once. Incidence, on the other hand, is how quickly a disease is spreading within a given population. So you want to know the number of new cases of a particular disease that was diagnosed between two time frames or two designated times. So you want to, whenever you're collecting data and you're wanting to know the incidence of a disease, you are going to collect data at one point in time, and then you're going to collect data a little while later, so at a second point in time, and you're going to see how many more new cases developed during that time frame. And it's essential that you use the same measure each time, so you collect the data the same exact way each time that you're collecting data. So the number of new cases actually goes in your numerator, and then you're still going to divide by the population at risk, and then if you want to express it as a percentage, again, you're going to multiply it by 100. So let's say, let's use the same example that I did for prevalence. So I still have 125 sixth graders. And let's say the very first day of school, I screened the 125 sixth graders. And the prevalence of dental caries on the first day of school was 40%. So then I come back in the very last day of school, and then I am going to collect the data on the very last day. And what I found was that during the school year, there were 20 new cases of dental caries that happened in the sixth grade year. So what I would do to determine incidence would be, I would put 20 in the numerator, because those were the 20 new cases that happened between the first day of school and the last day of school. So those are the number of new cases. So 20 divided by 125, so we still have 125 sixth graders, and that gives us 0.16. If we multiply it by 100, then we would know that our incidence is 16%. So basically, what we can say is that when we report the incidence of caries in the sixth grade population is 16%. It means that 16% of the population at risk for caries developed new caries in that 9-month time period. Now, what's really interesting is that short-lived diseases like the flu can have a high annual incidence, but a low prevalence. But a lifelong disease, like a chronic disease like diabetes, can have a low annual incidence, but a high prevalence within a population. So you can have high incidence, low prevalence, and vice versa. The way that I remember incidence and prevalence is I look at the first letter in the word. So prevalence is a P. There's only one P in prevalence, so I know that they're collecting data once. When I look at incidence, there are two I's in incidence, so I know that they're collecting data at least twice. Hopefully that little tip or trick will work for you. I know it works for me because, you know, like I said, a lot of people will use them interchangeably. Relative risk, once you know incidence, you can calculate relative risk. And basically, relative risk is an assessment of the relationship between an exposure to some kind of health risk factor and the disease. So it really measures the strength of the association between the risk of exposure to an outcome compared to the risk of a non-exposure to the same outcome. So basically how you calculate relative risk is that you, in the numerator, you put the incidence that you found previously in a group exposed to some type of factor, and then you divide that by the incidence in a group not exposed to the factor. So for instance, if we wanted to calculate the relative risk of caries, we could, and we really wanted to know how protective or non-protective fluoride is in terms of caries development, what we would do is we would get the incidence of people that developed caries that was exposed to fluoride divided by the incidence of people that had caries not exposed to fluoride. So let's say we got a incidence of 0.25 being exposed to fluoride. So that would be in our numerator, 0.25. And then our incidence is 0.50 for those that were not exposed to fluoride. So when you divide 0.25 by 0.50, you come out with 0.5. That's your outcome. So how you interpret that is that if you have a outcome or a number that is less than 1, it means that you're at decreased risk of getting the disease if you're exposed to that factor. So since we were looking at fluoride and our outcome, our relative risk was 0.5, then we would say we were at decreased risk of developing carious lesions when we're exposed to fluoride. If our relative risk was actually above 1, greater than 1, we would say that we were increased risk of obtaining or developing carious lesions. If it's equal to 1, that just means it's a wash. There's no risk at all. Let's do the COVID. So let's say we have an incidence of people that were exposed to the COVID virus, and that was 0.50. And then we have an incidence of people that were not exposed to the COVID virus, and that was 0.25. Our outcome, our relative risk outcome, would be 2. So that would mean how we would interpret that is that those people that are exposed to the COVID virus is at an increased risk of developing the virus later on. So those are some great terminologies and some ways to look at some data, but there's some other ways that we can measure diseases as well. The first way is a count. So basically a count is an absolute number of people that may have a disease or not. So a count is really useful in unusual conditions, a very rare condition. But there's a huge problem with count. We don't know if there are little or a lot of cases if we don't know the population as a whole. So let's say we have 384 people at ULSD that are a perio maintenance patient. So they're 4910. They're coded a 4910. It's a very simple measurement. We just say how many people have that condition, or in this example, how many people are perio maintenance. The problem is we don't know if there is 384 people at ULSD are perio maintenance out of 500, or if they are out of 50,000. So if they're perio maintenance, 384 patients that are perio maintenance out of 500, that would mean that there's a lot of people that are coming in that have had perio treatment at ULSD. But if there are 384 people at ULSD that are perio maintenance patients out of 50,000, that would mean that we don't really have a perio problem at ULSD. So if you just have a count and just report out the number of people that have a disease or whatnot, then it's not very useful at all. So I gained this graphic on March 29th from CNN, and you can see cases in the second column. So the states in the first column, the second column is cases. So, okay, if you go down, Florida has 4,238 cases. that doesn't really mean a whole lot because maybe they only have 5,000 people in Florida, and that would mean a significant proportion of their population had COVID. Whereas if their population was 500,000, that would be a very small percentage of people that had COVID within Florida. So hopefully you can see how that's not very useful in terms of reporting measures unless you have very unusual conditions. Like my brother has his Langerhans cell histiocytosis. He was diagnosed with that, and they do report that in terms of counts because it's a pretty unusual condition. So more often we'll see reports in proportions or rates. A proportion is just basically a count divided by the population number. And then a rate is a proportion, but it uses a standard denominator instead of the total amount of people within that population. So you can see that actually in the third column of that CNN clipping there. You can see it says cases per 100,000. That's a rate. So they're actually looking at, and they're doing the math here, and like with the Florida, they would Florida case, they would say that there's 4,238 cases per 100,000 that will give us a rate of 20. So that allows us to compare apples to apples instead of apples to oranges. Something that is probably the most useful, specifically in terms of oral health diseases, is an index. It provides a lot more information, such as disease severity. So a count, a proportion, and a rate just tells you how much of that disease or condition is out in the community, but an index can tell us the severity of that disease and condition. So an index really can be used to educate, to motivate, and evaluate a patient or a community. And it can also be, honestly, used as a legal record later on. So let's really focus the rest of this particular video on a dental index. So a dental index is really an expression of clinical observation of severity of oral diseases, and we put a number to it. So we put a numeric value, and usually it's based on a graduated number scale. So we have an upper limit and a lower limit, and usually the lower limit means that you're healthier. And the upper limit means that you have a significant or severe oral health disease there. And then we gather this data through epidemiological screenings. So through those observations. We do this actually in clinic already. You probably just didn't know that we did it. Our dental hygiene perio classification in clinic, where we classify periodontal health as a 0, 1, 2, 3, or 4. And we know that 0 is super healthy, and a 4 means that their teeth are really flapping in the wind, basically, and they have no bone structure. And then we also pair it with an A, B, C, or D, and that is clinical difficulty. So how much stain or calculus buildup is present? And again, an A means that there's very slight calculus or stain, and a D means that you have wall-to-wall stain or wall-to-wall calculus, or both for that particular patient. We can classify indices in several different ways. An index can be either a simple index or a complex index. A simple index just basically means that it is measuring whether a disease or a condition is there or not. So it's dichotomous in measure. So we say, yes, a disease is present, or no, a disease is not present. We do this with our bleeding on probing whenever we're doing our perio charting. So we say, yep, there's bleeding there. Nope, there's not bleeding there. A complex index is we're really measuring the severity of the condition. So we're saying whether it's slight, moderate, or severe overall. We can also look at it in terms of cumulative conditions or conditions that are just present. A cumulative index means that it measures all evidence of a condition, so past and present disease statuses. We see that a lot of our caries index or indices are cumulative because we can see whether they've had past treatment in terms of restorations or if a tooth has been pulled due to caries. And then finally, another classification system is whether an index is measuring reversible conditions versus irreversible conditions. Reversible conditions, reversible indices are just measuring conditions that can be reversed, like plaque status or gingivitis. Irreversible indices are measuring conditions that can't be changed, such as your clinical attachment levels or your caries, whether there's caries present or not. So in terms of, we have different classifications of indices, but every index possesses one of the scales of measurements, and there are 4 different scales of measurements, and you may recognize this from previous science classes. So indices can either be nominal, ordinal, interval, or ratio. Basically, nominal means that there's categories. This is very simple. You give names to different conditions. They're very mutually exclusive. There's no ranking to them. So it'd be like if we had gender, then we would know boy, girl, or other. If we were doing marital status, we could do married, single, divorced, widowed, etc., etc. We could say in terms, if we had a nominal index of pets, of dogs, dog types, let's say, then we could have poodle, we could have labs, we could have pit bulls, we could have Dalmatians, we could have beagles. So we're not really rank ordering those, we're just naming different categories. When we have an ordinal index, that means we have those mutually exclusive categories, but we're starting to introduce the rank ordering. So we're having like a little to a lot of education. Our Perio classification system is like this as well. So we're rank ordering in terms of severity, but we're putting a 1 or a 2 or a 3 or a 4 based on the presentation of their condition. I like to use the example of horse racing here. So we have win, place, or show. We have first, second, and third, basically, in horse racing, but we call it win, place, or show. There's not an equal amount between win, place, or show. So a horse could win by 10 horse lengths, or it could win by a nose. It's not equivalent there. So we're only rank ordering in ordinal. In terms of interval, we have those mutually exclusive categories. We have the rank ordering. Now we're introducing those equal distances between each classification. So, for instance, temperature is a great example of interval. So we know that there is a 1 degree difference between 45 and 46 degrees. And then let's say the next day we have 70-degree weather, and then it's projected for tomorrow to have 71 degrees. We know that there's a 1 degree difference in temperature between those 2 days. So it's equal. It's the same amount of distance between 70 and 71, or 40 and 41. So there's an equal distance between two adjacent units of measurement. Ratio is basically interval. You can see that they're all building upon one another. Ratio is basically the interval, but we have a complete absence of condition, or we have an absolute 0 point. So the typical example would be the Kelvin temperature scale. We can't have a negative temperature in the Kelvin temperature scale. Another example would be number of teeth. You can't have a negative number of teeth in a mouth. So there would be an absolute 0 point there. When we are looking at dental indices and we're utilizing dental indices, for the most part, almost all of our dental indices that we're using in public health to collect data are ordinal. So we're rank ordering the severity of the condition, but we don't have that equal distance between slight and moderate amount of a condition. In addition to having the scales of measurement, each index is also going to be categorized as one of these types of data. So it's either going to be continuous or dichotomous. So continuous means that there's a linear scale of measurement, meaning that you can measure anywhere along the scale. The fractions are possible. So let's say height. So we can go from 0.1 millimeter to 10 feet in height. And where someone falls in terms of their height can be anywhere along that scale. So, for instance, I'm 5'6", so I would fall kind of right in the middle of that scale if we were going from 0 to 10 feet. You can also categorize index as discrete. So this would be the linear scale of measurement. The biggest difference between continuous and discrete is that discrete, you can only measure in whole numbers along the scale. You can't use fractions along the way. So, like for instance, if we were going to look at teeth within the mouth, and so we have 32 teeth in the mouth, and we were utilizing an index that told us the number of teeth sealed. That would be a discrete index simply because we can't have like a half a tooth sealed. It's either going to be the tooth is sealed or it's not. We can also have categorical categories of data, just meaning that you're naming them. So this is where our nominal index would be. So you have categories of measurements. And then it could also be dichotomous. So you only have two categories there. And usually it's an absence or presence of a certain disease like BOP. So when we are developing an index, there are some characteristics of an ideal index. And this is one of the slides that I would star and no, because sometimes they will ask kind of the characteristics, the ideal characteristics of an index. The first one is that the index is clear, it's simple, and it's objective. So it just means that if I was a researcher and I was going out and utilizing an index out in the field, out in the community, that it would be really easy to implement. It has criteria that's very simple. It's easy to understand. There's no interpretation to it. They have mutually exclusive categories, that it's objective. The results are not subject to any kind of individual interpretation. And the ideal index would mean that you would have minimal equipment and supplies that are necessary, and you could utilize it pretty quickly and screen a whole bunch of people and collect a whole lot of data. Another characteristic of an ideal index is that it's quantifiable. So we put numbers to the severity of a disease so that we can statistically analyze it later on. The third characteristic of an ideal index is that it's sensitive. So remember in the last video we discussed what sensitivity means. So basically it's sensitive in shifts in disease. So it will detect a relatively small shift in disease. So let's say it will detect a very minute presence of a disease that's in there. So you don't want to say it's nothing or wow, it's a bombed out tooth. You want to be able to have degrees of severity in a sensitive index. A fourth characteristic is that it's acceptable to those being measured. There's no pain or discomfort. A fifth characteristic is that it's reliable. And here's some important terminology with reliability. We have inter-rater reliability, intra-rater reliability, and calibrations. Inter-rater reliability is defined as consistency amongst all screeners. So let's say Ms. Myers, Ms. Drury, and I are a research team and we're going out into the Shively community and we are collecting data, oral health data. If we have inter-rater reliability, it means that the three of us are collecting data the same exact way and interpreting data the same exact way every single time. So there's consistency amongst us. Intra-rater means that there's consistency within one single investigator, but they're consistent every single time they're collecting data. So let's say I'm the only researcher on a research project and I'm collecting data over the course of 3 weeks. So I want to make sure that I collect data the same way on Monday as I do the Friday before. And if I'm collecting the same way, the data the same way, that means that I have intra-rater reliability. The way that we can actually increase our reliability, increase our consistency, is through a calibration session. This is a session where examiners undergo education so that they can be consistent. So for instance, every August your faculty gets together and we have a 2 or 3 day calibration session where we interpret the different rubrics for clinic and how we're going to grade certain skills that you have. So we undergo a calibration session in attempts so that we can have consistency amongst all the faculty. We also want an index to be valid, meaning that it's measuring what it's intending to measure. So this is closely tied to the clinical stages of the disease. So some considerations when you're a research team and you're trying to pick out the dental indice that you want to utilize in the field. What you'll see in the next lecture is that there are different dental indices that measure the same oral disease. Like for instance, for oral hygiene status and gingival health, we're going to go over 7 different indices. So there are different indices that will measure the same disease that are out there. And there's not a consensus as to which one is better than the other. It really just kind of depends on the purpose of your research project. We also need to consider our team of researchers. And do we need to have researchers or the team of people that are collecting data, do they need to have a higher degree of clinical judgment, or can we get by with people that don't really know dentistry, like a hygienist or a dentist? So what we see in public health is that there's a trend going to less extensive indices where we can get by with using non-dental people to collect oral health data, like public health nurses. So you don't want a public health nurse to use an index that would require somebody to use a probe to collect data, because that public health nurse has never been trained on how to use a probe. So typically what would happen is those researchers would pick a index that wouldn't require that clinical judgment of how to use a probe. They would pick another index that was more appropriate to their research team. There's some difficulty utilizing these in the field within the community. Some of these indices, you'll see that they want you to disclose the participants, or they want you to air dry the mouth and then collect the data, or they utilize a perio probe to collect the data. So some of those are a little bit more difficult to use out in the community. Let's say we're collecting data in elementary school gym. It'd be really hard to set up an air water syringe there. So some of these indices are a lot easier to use out in the field than others. And then what you'll see is that Carey's indices are much more standard overall compared to the oral hygiene indices and the perio indices. And you'll also see out whenever you're reading research reports that, the Carey's indices are reported a little bit more frequently, and that's because they're much more standardized overall. So that is the intro for measuring dental diseases. In the next lecture, we're going to be actually talking about the nitty-gritty details of several common dental indices that are out there and that are being used.